Healthcare professionals were faced with overwhelming challenges when COVID-19 suddenly struck slightly over 1 year ago. Peter Cordeau, president of Norwalk Hospital, will join us today to share how Norwalk Hospital staff members rose to the challenge to care for their patients during this pandemic. Stay tuned for an amazing and inspiring account of what it was like being on the front lines. Health Talk is up next. Hello, I'm Dr. Eric Mazur. Welcome to this week's Health Talk. Today we'll hear the inspiring story of how our community-based hospital responded to being on the front lines early during this national pandemic. Joining me is Peter Cordeau. He's president of Norwalk Hospital and a repeat guest on the show. Peter, so good to have you.
Thank you for having me. Pleasure.
Now, you didn't start very long before the pandemic hit, did you?
No, it was just about my 1 year anniversary when the pandemic hit.
So just as you got to know everybody's name.
Exactly.
And tell me, what was it like in the early days? Did you, back I guess in January, did you know it was coming? Did you have time to prepare, or did it just roll over us like a tsunami?
You know, now that it seems like it's been here always, we were actually preparing in December, back when we didn't know what the pandemic was going to bring. And if you could bring yourself back a year ago from this past Christmas, you know, we had Dr. Fauci telling us, well, it'd probably be like the flu, and there was really not much to worry about, and we thought it wasn't airborne and it was only on surfaces. But at the same time, we as a healthcare organization were preparing for the worst. And it's very difficult to prepare when you have absolutely no idea what's coming. So we were practicing and rehearsing across the entire health system on what to anticipate, from personal protective equipment to increasing our ICU size and our staffing size. And the state actually started to get on board with that also as the months continued.
And this all started in as early as December?
Yes, December of 19.
Yeah, wow, that's pretty impressive. So can you just run through some of the challenges that you and the staff faced? As you said, it's hard to prepare for something that is completely unprecedented.
Yes.
I know, as a physician, I never faced anything like this at all. Maybe HIV was the closest, and that was very different because it was not as contagious. We knew how it spread really right as it appeared.
You know, it's funny you mention HIV, because in some of the op-eds I've written in the past year, I do mention that as a ICU nurse at the time and how afraid we were to care for these patients. And this is very similar from that perspective. But the difference here is, or the difference between both is, we had this massive influx of patients almost overnight. And the very first patient that came into Danbury Hospital, and the next day, the second patient in the state was at Norwalk Hospital. The work that was involved, our docs were saying, how are we going to take care of more than one or two of these patients? By March or April, we had over 100 COVID inpatients. Wow. In this hospital alone. And when the mandate from the state, or the edict from the state, and you saw this in New York too with the hospital ships and the Javits Center and things like that, is we had to essentially find places to double our size. So we had a satellite ICU, and anyone who's had the opportunity to be in our GI suite here at the hospital, that became our COVID ICU. And it was unbelievable the amount of work that went into creating that, how stressful an environment was, how everybody was dressed up as if you were from outer space, and at the same time, the most amazing care being delivered in a space that we put up overnight. The facilities teams in our hospital and others in the system, are also unsung heroes. They built units like overnight to house patients safely, care for patients. The other big important part of phase one that's different than phase two is that we ceased all elective surgery.
Good to bring that up.
So we had a lot of skilled hands, although not necessarily for what we were using them for, and we repurposed staff, and staff voluntarily said, I'm up for the challenge. I will be there to assist, whether it's in an ICU or any of the med surg floors. So we it was really heartwarming, the support, the real commitment to caring for your community during that time. But I could say that there was a point right before the peak in April where you were saying, I don't know if we can take care of another ICU patient. We started to see ICUs similar a little farther down at other hospitals in the state where their ICUs were full and they were looking to transfer patients out because we were all getting over full, and then slowly it started to wane.
It's an extraordinary story. I think also people may not realize that, maybe we've realized here, I was living up in the Hartford area, and what was happening in Fairfield County was just what was happening in New York City. New York City got all the national play, but the numbers and the spike were virtually identical.
Correct.
So it's not as if we had them as a model to how to begin to respond to this pandemic. I also heard that other wards or administrative wards were repurposed for inpatient care. How did you do this?
So very interesting. We actually rented a bunch of beds. We bought a bunch of extra beds, and we started creating floors back in December. We started to create units. We moved all of outpatient psychiatry, and we moved them out, and we created patient rooms because a lot of hospitals have more licensed beds than they have physical beds. So a lot of those old patient units were converted to office space. So we kind of undid the whole process. The state came in and blessed the space, so to speak, and we actually converted our pediatric unit into a unit, outpatient behavioral health, as well as some other empty spaces within the hospital. And GI is a great example where we turned an ambulatory GI suite into an ICU overnight.
And you've mentioned the staffing, and it's no trivial issue. ICU medicine is different than post-op recovery medicine, and it's different than post-GI procedure medicine. It's different than hospital medicine, and yet my understanding is all these people pitched in and quickly became intensivists.
Correct.
Was there an educational process you somehow went through while you were repurposing these rooms? And then people must have worked extra hours, extra shifts to cover this. I don't think people realize that at home. You just can't take a nurse who's a pediatric nurse and throw her into an ICU.
Correct. However,
anywhere you can throw me into an ICU.
Yeah, well, that's funny you say that because I myself, after the first patient came in with 2 weeks of close, said, I'll do whatever I can. I still have a nursing license. There are certain things I can do that I'd feel comfortable with and certain things I can't. But that pediatric nurse, for example, what they could do is do the physical care on a patient. They could transport a patient. They could be an extra set of hands. So how you made up for a lack of skill per se, you had more decision makers guiding other people.
People working right at the peak of their expertise.
Absolutely. And the other thing that we're very blessed with here at Norwalk Hospital is we have a pulmonary fellowship program. So not only did we have intensivists, we had a bunch of fellows, physicians that have already went through their residency and now are going through additional training to be pulmonary fellows. So we had a really sophisticated group of physicians to provide that extra layer of care. Plus, Dr. Jeff Nicastro, who is now the CMO of our system, is a surgical intensivist. And so he coordinated all this care across the system. So on a daily, if not hourly basis sometimes, would be communicating across all ICUs to ensure that we had the right resources, or if we had to transfer patients or whatever we needed, even equipment-wise, throughout the system.
Did staff travel among the different hospitals in the system in order to provide coverage?
We had some with respiratory. Respiratory therapy was an expertise that was very limited across the system. Never, have anyone really come across that great need of care. So respiratory therapy, some nursing, physicians, because the states waived the licensure requirements across states to provide care.
Across state lines? You could.
Correct. So we were able to cross-cover if needed for all those services. I think another big important part that we're very fortunate with as part of Norwalk Hospital and New Vance Health, being part of a system. Boy, you really start to appreciate the power of 7 hospitals and the power of a system. One, from the personal protective equipment and all the durable medical equipment to be shared across 7 hospitals. ventilators. Sharon Hospital, where I originally came from, they sent us down ventilators, they sent us down beds because they were not experiencing the same level of
I certainly
COVID.
noticed that from my perch in Hartford, that it was very different up there than it was down here.
Yeah.
I mean, the Fairfield County was really as acute as New York. It got bad up there, but later a little bit more prolonged and never quite as acute as it was down here. And
Right.
by then, some of the supply lines had been established. I did want to ask you about that. What were some of the biggest challenges in terms of PPE, personal protective equipment, staff reluctance, unknown therapies? People didn't even know how to treat these folks.
All great questions. Let's see. Well, let's start with treatment before PPE. The treatment evolved. The difference in if we get into phase 1 and phase 2, the treatment evolved so quickly and almost daily that it became very difficult to provide care. We were involved in investigational studies for remdesivir at the time, which was the antiviral. We were in
Ultimately proven successful.
Correct.
Not a cure, but ultimately proven successful.
And we were one of the first in the trial, so we applied immediately with our first patient. We were able to give that patient remdesivir. But then the belief was early intubation for a patient, which turns out to be not to be wrong, right? So initially the first piece of equipment was a ventilator. Everyone was scrambling for ventilators throughout. We were on calls with companies in Israel to see if we could get ventilators in-house. We were trying to figure out ways how to split a ventilator, to have one ventilator to ventilate two patients.
Did the feds get involved, or was this mainly we worked through our state representatives who were interfacing with the feds?
A little of both. We received some ventilators from the government.
The reserve?
Thank you, the reserve, and they all needed to be repaired, you know, so we...
I'm sorry to laugh.
Yeah, so we got the ventilators in, and we did. We were able to bring them back into service, which was great. We also converted anesthesia ventilators, which are primarily for short term, and they don't have the same buzzers and whistles that your full-blown ICU ventilator will have, but we were able to convert those ventilators also. But as we learned later in the pandemic is once people were intubated, there was no coming off that ventilator.
Also, I do remember when I was chair here that we were very early in looking at prone ventilation, which turned out to be something very beneficial to these folks. Were we doing that early here because of our experience with prone ventilation?
We actually had proning teams, right? So it allowed us...
So which means for folks at home, really ventilated on their stomach rather than on their back.
Correct. And we were able to do that, you know, with the extra sets of hands. There were groups of people that were, their only job was to prone patients.
You know, we have 1 minute left.
Yeah,
and,
sure.
We could go on like this for hours, it sounds like. Do you have any final comments you want to make to the staff, to the community about the response to this COVID tragedy?
Absolutely. One, can't thank the staff enough. We've all gone through a lot. Their families, the fear of bringing COVID home, yet understanding what their role is in their job and their service to the community. We could never, ever thank the staff enough. The community response, as we just got another wave of Girl Scout cookies literally about 5 minutes ago.
Point me in that direction.
Yeah, we'll point you in that direction. The community support was overwhelming. Overwhelming support to the point that whether it was that flag raising in the front of the hospital brought tears to people's eyes, just overwhelming. And when you go into administration now, we still have the drawings from children in the community thanking the heroes of the hospital. So we will never forget the community.
It shows you what the heart of healthcare really is,
Yes.
and what a community hospital really does for its community. As I said, I'm so sorry we've run out of time. I want to thank my wonderful guest today, Peter Cordeau, for joining me on Health Talk today. Please share your questions and comments with us by contacting us at healthtalk@newvancehealth.org. I'll see you next time.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
Staying 6 feet apart, frequent hand washing, and wearing face masks are just a few of the visible changes we've all experienced due to the COVID-19 pandemic. On this week's Health Talk, we're going to discuss additional pandemic-related changes that are not only impacting healthcare delivery now, but are likely to persist and change healthcare in the future. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about how healthcare has been changed by the COVID-19 pandemic and how that is likely to affect healthcare delivery in the future. My guest is the perfect guest to answer this question. He's Peter Cordeau, president of Norwalk Hospital. You've lived through this epidemic. We're still living through some of it. I guess I should point out we are following our infectious disease rules. We both have been vaccinated. We both are fully immune, and we've been advised for this we can stay 6 feet apart and not wear masks. So we're not violating any rules by this conversation.
That's correct, and it is refreshing to be able to be sitting in a room having a conversation with
It sure is. And as someone who doesn't hear well, it's a pleasure to be able to see your lips. So Peter, you know, I guess this is trying to predict the future, but boy, I know that things like telemedicine have changed. This rapid accrual of staff, expert staff that's now unwinding. What things do you see sort of persisting into the future? What effects is this going to have on healthcare?
My hope is that telemedicine is here to stay for a lot of it, especially the follow-up visits that do sort of clog up the system from time to time. I do see, though, when you ask a pediatrician, pediatricians' offices are empty. There's no respiratory illness. There's been no flu. I think we've learned a big lesson from the cold and flu season about wearing masks. I'm not sure the mask is going away for those who are sick. The hand washing and mask wearing has really made a significant impact in the overall.
I just want to emphasize that point. There's been no flu season this year.
None.
Experts were predicting this double spike of COVID and flu. No flu. And I didn't realize that even colds, minor colds, are down with it.
Yeah. Oh, absolutely. As a matter of fact, you know, we're not seeing any of that volume through the ED, and I know through other physicians here whose spouses are pediatricians, the offices are empty. The school system, you know, we're fortunate where I live that they've been in school all year physically. The kids just aren't sick. So I think that'll be a change for the future, and I also believe that you know, our ability to identify patients with the technology that we have prior to coming into the hospital also will reduce a lot of the hospital-acquired infections that we find that patients are bringing in to the hospital pre-procedure or before they walk in the ED.
Do you think people will be more conscious about using PPE and isolation of sick patients? I mean, it used to be we'd have an occasional TB patient or an occasional patient with a resistant germ that we would isolate, but now we've had such tremendous isolation. Do you think that's raised the consciousness and made people a little bit better at doing this?
It has, and for a couple of reasons. One is the understanding that bringing groups of people together in a smaller confined space increases your likelihood of that happening, so much so that we have a category called a PUM, a patient under monitoring, right? So even though you might test negative for COVID, coming from, for instance, a nursing home puts you at higher risk to have something, so we're gonna isolate you anyway. So it has created another layer of protection and surveillance that didn't exist prior to COVID.
And I'm sure there are medical things we've learned from COVID. I don't want to get too much into the weeds, but do you want to mention any of those in terms of ICU care or ventilation or? And I actually do want to talk about vaccination because I think that's going to change the world.
It is. What we learned is high flow oxygen is certainly the way to go, heated high flow oxygen versus intubation. But what we saw post the viral component of the infection was really that inflammatory response. There was multi-system organ failure, patients needing dialysis, severe respiratory complications. It was that post-COVID, to the fact that now on West Main Street we actually have a COVID clinic to treat patients who still have what they call, they're the long haulers that have a lot of post-COVID symptoms. So we're still learning a lot about it, but we are very, from steroids that were prohibited in the beginning are now a frontline treatment. A lot is being learned in terms of the long-term disease process of post-COVID infection.
Yeah, you also mentioned the intubation for folks at home. That means putting a breathing tube down into somebody's throat. And certainly when I was active as a resident and seeing these patients, if somebody was beginning to struggle, the tube went in.
Absolutely.
And now we learned with the COVID patients, that's not good for them. We want to do that only as a last resort.
Yeah, so it was against all conventional wisdom, right? All of what you would practice and learn was really reversed as we learned.
And even the prone ventilation, which I know we were doing here at Norwalk very early on because we had a very rapidly adapting ICU. Early on, not from just from COVID, but just in respiratory failure. But that became standard of care now.
Correct.
For the COVID patients.
Yeah, and even the non-intubated, the ones on the floor, were being prone.
Now, can you say, do you want to talk about, I'd love to talk about vaccines because I think this experience with RNA vaccines directly drawn from the genetic code of the virus is going to transform our ability to deal with these in the future. Do you want to say a few words about that?
We totally agree. So what's interesting, and this room was actually ground zero for vaccination. And when you're getting to the year anniversary at the time of the pandemic or near a year, because I think it was December-ish, where people were really down in the dumps, this place was like Disney. It was this overwhelming feeling of, we're going to get to the end of this. Most, if not all, had no symptoms or side effects whatsoever, worse usually being a sore arm in the end and some mild aches and pains the day after. It's amazing, the technology, how it's worked, how effective it has been for us in just knowing. We knew that shortly after the virus was identified, they were already in the process of trying to figure out a vaccine, and there were people that were smart enough to know what to do. So it is fascinating, the technology, and I really encourage those watching to get vaccinated. There's no fear.
We have both been vaccinated. I said it at the beginning of the show. I ran out. As soon as I was eligible, I ran out to get the vaccine.
And now it's 16 and older, and my 18-year-old was vaccinated here at Norwalk a few weeks ago. So I really encourage those that are capable of getting the vaccine to get the vaccine.
Yeah, it changes how one feels about your own risk. Especially, again, I'm over 70, and I knew the data that was put me at high risk, and it's freeing. And now here in Connecticut, I actually just looked at the data yesterday. Very few people over 70 are getting sick.
Correct.
We're seeing the effect of the vaccine. I think we're beginning to see Connecticut go into its nadir again, but the vaccine really does work. And I do want to point out, this is a new technology. Maybe people not realize this, but particularly the Moderna and the Pfizer vaccines are a brand new technology of injecting RNA, coding for a piece of the virus directly into the muscle. And that's so translatable to other viruses. It's expanded. You can do that for any virus as long as you know the piece.
Right.
And incredibly exciting.
Versus the old method, right, where you were kind of growing that virus and having a deactivated version of that injected.
Or even active.
Or active, right.
So the early polio viruses or I should say polio vaccines, which still could give people an occasional mild case of polio. So this is going to change things, I think.
It is.
I think we're going to see the COVID vaccines perfected and see new generations that are perhaps less susceptible to some of these mutations. And I'm very optimistic that SARS and MERS will be controlled before they ever get out of the box.
I totally agree. It's been wonderful experience and a once in a lifetime experience as a nurse, as a physician, as an administrator. I hope no one ever has to go through this again, but you're seeing really the advancements of medical technology and how it can work really at the press of a button.
Yeah, and I think there's a lot of strife in this country right now, but America can be pretty proud. This was our medical complex, our medical industrial complex in partnership with the government that came up with an extraordinarily effective vaccine in 9 months. I think it's breathtaking.
It really is.
And almost miraculous. And we are going to see the end of this pandemic very soon as a result of this vaccine. It's striking.
I agree. And one of the articles I read, I think it was this week, I think every week an additional 10% of Connecticut's population is being vaccinated. So you start to see how quickly, we're going to be surrounded by people that all have immunity to this virus. And then the next question will be the booster, but we can all handle that.
Right, that won't have to, I've discussed this with my family member, that doesn't have to happen with the acuity that
Correct.
We had to get this into as many people as fast as we could. A booster, we could spread that out over a month or two. The immunity doesn't drop off a cliff.
Right.
And I'd also like to say, I think there's a lot of misinformation about immunity. There's a lot of, right now we're using the surrogate measure of circulating antibodies as an indicator of immunity. That's one measure of immunity. Those always fall off after a vaccine.
Right.
There are memory B cells, I don't want to get too technical, but I've heard other lay people talking about this, memory B cells and T cells that are much more long-lived, which we're not testing for regularly. They're hard to test for. So I think immunity, we're going to have immunity. It may not be perfect immunity, but this immunity is going to last for a while. And if we need a booster, we need a booster, but it's not going to be, as I said, their immunity isn't going to fall off the cliff come July 1st or August 1st.
Right, and if you're comparing this to the flu shot, there's no comparison.
No comparison.
To the effectiveness of this compared to a flu shot, which is really a coin flip.
Right, because flu redresses itself every year. It's very different than, people don't make that distinction, but the COVID is having mutations. Yes, it changes the surface coat a little bit. It may make it a little more infectious or less infectious. But in general, this panoply of antibodies and responses that we produce pretty much handles it. Mm-hmm. At the very least, it keeps you from, nobody who's been vaccinated is ending up in the hospital.
Right.
So maybe it's not 100% keeping me from getting the sniffles but it's not, I'm not going to die now.
And there are very few documented reinfections too, which is...
I agree. I think, I did want to say, my sister, who has some immune problems, is in her late 60s, literally cried after she got it. She called me up on the phone. She was so emotional and so happy to have gotten this. And I am concerned about the resistance in the community. I don't entirely understand it. I know there's always suspicion. This is not being done for money. This is,
Right.
this is really a healthcare triumph for all of us.
And we are out there, just, the Norwalk community, the FQHCs, the state of Connecticut. FEMA is actually going around with a van through all the states, and I think we have it for about a month. I believe it's in the state now. But to go out to those communities who have trouble with access to vaccinate.
Yeah, I think it's just, and now President Biden's come forward and talked about employers giving time off for people to get vaccinated. There really is no excuse not to get vaccinated unless your physician tells you for some reason you shouldn't be. But this is not even, it's not a live virus. It can't hurt you.
And we're starting, just so you know, we're starting on patients that can get it on discharge or getting it on discharge too.
That's great.
So we're starting that process also.
And we've run out of time again. This is really a wonderful story. And Connecticut has done extraordinarily well. I think we've really
Two or three in the country.
I think we've done great. So we've run out of time. I really want to thank my guest, Peter Cordeau, for joining me on Health Talk today. And please, thank you for watching. Please share your questions and comments with us by contacting us at healthtalk@newvancehealth.org. See you next time. And if you take one message home, please, if you haven't been vaccinated for COVID, please do so.